Thank you very much, Michael. As our first panel comes up today, it'll be led by Will Alacey. Will's in the partnerships at the Duke Institute for Health Innovation, and he will help introduce the four panelists that he'll be discussing with.
Yeah. Thanks a lot. Hey, it's good to see you. So,
all right, so I'll wait for panelists to get up here, and then I'll introduce them. I think Drew and Michael had some great points. I would agree with most everything Drew said. There was one thing that I would just like to get on record and say I disagreed with, just in all honesty.
Give me one.
An app that would be able to tell me what wine I should drink should absolutely be considered digital health. So I don't know how that wouldn't be, but anyway. So yeah, just like the other people who have gotten up here to speak, thanks to John and Erica for putting on such a great conference, right? The ability to not just talk about mHealth, but to really think about, okay, how do we really identify what are the problems? How do we ideate on solutions? How do we work with institutions to pilot these solutions? And then on the back end, how do we measure and evaluate the success of those? I think you're going to see like all of those points throughout. What our panel is meant to do is to talk about, is your solution feasible? And feasible, I should have looked this up before, but I just Googled it. So possible to do easily. So given that we are not in a complex healthcare environment, I think that that should be an easy thing to solve. I work within the Duke Institute for Health Innovation, where still a relatively nascent organization, but really with the clear focus of implementing new models of care or new technologies into the care setting, trying to provide capabilities to our PIs to help them with that integration into the care setting. Integration is a word that was mentioned a lot. And I think there is a really good point of integrating in with like the EHR, for instance, but I think there's another point where you mentioned the care manager. How do you actually integrate into the clinical workflow? So I think that's another thing that we will certainly discuss. Back in 2016, I think it was like $7.9 billion was invested in digital health technologies by venture capital firms, and you can sit here and wonder, man, which of those are really going to have an exit? Which ones are going to be acquired? And this isn't the case every time, but I would say most of the time, it's going to be the solutions that have gained adoption by both patients and providers. So I think that I think in this segment, how do we figure out which solutions are feasible, which ones are possible to be implemented easily? Then we have a great panel from the perspective of providers, payers, and then also looking into the global space. So I'll first introduce our panelists. First is Matt Crowley. He is an investigator at the Durham VA Center for Health Services Research in Primary Care, also an endocrinologist here at Duke. But Matt's a principal investigator on 2 trials evaluating telemedicine and e-health interventions for patients with persistent, poorly controlled diabetes. And we had the fortune of being able to fund one of his projects. Next is Harriet Burns. She got her medical degree from Duke and completed her MPH in epidemiology as well as her residency in internal medicine and pediatrics from another institution here in the Triangle. I could make that joke, but honestly, they just ran the table in March Madness, so let's just give them credit for who they are. She, for the past 8 years, she's worked at Piedmont Health Services, which runs 10 federally qualified health centers, so FQHCs, which I think her perspective is going to be very, very vital in this panel, and is also the Associate Medical Director and the Director for Informatics there. Next is Jane Brown. So she's the Principal Strategic Advisor within the Chief Strategy Office at Blue Cross Blue Shield of North Carolina. Before that, she was a principal at Mosaic Health Solutions. As you all know here, that is now Echo Health Ventures. and I see Blake Long here, who will be talking later. And before all this, she worked with an academic medical center here in the area around clinical service line innovation. And finally, Trinity Zan. So she's from FHI 360's research utilization team. Her subject matter is specific within digital health and how you scale up digital health solutions in the global space. She currently serves as FHI 360's lead for digital health under the USAID-funded Knowledge for Health 2 project, not to be confused with Knowledge for Health 1 project. That's a terrible joke. I thought about not saying it, but in that moment I was like, let's go with it. And she has lived in Senegal and speaks French and Wolof. Just poll the audience. Does anyone else, show of hands, speak Wolof? You uncultured people. So, to be able to kick off our panel and talk about feasibility, I really truly believe before we can talk about solutions and which solutions are feasible, I think there becomes a problem when you talk about digital health is that a lot of people want to create solutions, and it's really fun to create solutions, but they almost do it in a way in which you've almost forgot to figure out what is the problem I'm trying to solve for first. So I could go through and I can ask each of you like what problem you think needs to be solved, but I think that would be very specific. What I'd probably be more interested in is how you go about actually identifying what are the problems that need to be solved. Harriet, I'll start with you.
Sure. I was thinking about that question, and I get a lot of requests, and the ones that the way that I identify what is a problem that needs to be solved is when I get a certain number of emails over and over again, and I realize, like, okay, I probably should address this. And so an example of that in our organization is annual wellness visits. We have been working on increasing the number of annual wellness visits that we do for our Medicare population, and we just don't have a very good workflow, and we definitely don't have the right forms in our electronic health record to accomplish that in a feasible way. And so finally, I bit the bullet and put together a working group, and we've started meeting and discussing how are we going to approach this. So email is the key way to identify for me.
Jane?
So, I don't know. Is that better? Can you hear me?
I mean, I can hear you. I don't know if they can. Yeah.
Right? I don't think. Like that? Oh, okay. So, from a Blue Cross's perspective, we think about the consumer's journey through health, and throughout that, we examine and take a pulse on where they're having hassles and where that they're not able to use the system as intended or as they want to. So we do significant data analysis across the health journey, from when they're trying to decide what kind of product to have to how they manage their health. And from that, we try to really focus on things that we would say are impactful and actionable. So really that's a bit of a science, because some things will make a difference, but you really can't do much about it. So we spend a lot of time thinking about it that way. And also also the connection with our consumer service. We get hundreds of thousands of calls a year and track what those are and who is calling us, why they're calling us, what they were trying to solve, and use that to inform our business decisions and objectives for transformation.
So from my perspective as a provider and a researcher, I think that is a really good question, because this question of are we addressing a need, as alluded to by our prior speaker and by Will, really I think gets at the heart of whether innovation will be used in practice. So to me, I think about outcomes. Is there a point where we're having outcomes that warrant innovation? This can be clinical outcomes. In my case, I'm an endocrinologist. I'm interested in diabetes. I've struggled with some of my very resistant diabetes patients in clinic for so long, that kind of drove me to think about other ways to provide care. It could be from healthcare system perspective, high utilizers, for example. Utilization is often driven by a core group of patients that disproportionately utilizes care. And it could be other outcomes like patient-centered outcomes, things that would inspire people to want to use an innovation.
Great. So I'm the odd person out being from a global health setting, and yet a lot of what my colleagues just mentioned, as well as what Michael in the earlier session mentioned, are absolutely relevant and pertinent. And so in the global digital health space, we kind of have a set of operating principles that are called the Principles for Digital Development. 9 principles that vary from design with the user in mind, to understand the overall ecosystem, to don't make something new, reuse when you can, interoperability. So all themes that you just heard, which all really center around having an excellent and deep understanding of the context in order to really be able to identify what those problems are. And I think to Matthew's point, we often look for the outcome level problems and then try to work backwards to the root causes, and then ask ourselves a series of questions using data that we've been able to accumulate, whether it's quantitative data from patients, whether it's qualitative data through key informants of providers, to understand, for example, are these community level health workers not counseling young women on certain contraceptives because they don't understand what the criteria are and the screening criteria, or because the paper job aids that they have don't really make sense and they're cumbersome? That might lead us to say that a digital solution would be appropriate because it can affect at multiple levels. However, if the problem is that they simply don't believe that young people should be having sex, then we have another problem that we need to tackle, which may or may not be via a digital solution. So again, we use a range of data points and think about all of these things, but really what's required is a very deep understanding of the context in which you're going to be operating so that you can really identify what those root causes are.
Yeah, thanks. I got an angry Snapchat from someone in the back who can't hear any of you, so you may just want to take the mics and hold them from now on. Again, like really this panel is about, looking at solutions that are feasible, right? Can they be implemented easily? What exactly does that mean? So from all of your perspectives, like when designing or evaluating a digital health solution within your space, so whether it's within a federally qualified health center, a payer, a provider in the global space, what are the most considerations that you or your organization have to evaluate whether or not something is going to be feasible? Again, defined as, the possibility of it being easily implemented. Anyone? Yes.
I'll jump in here to start the ball rolling. Can you hear me? Whoever just sent that backtrack? Okay. Don't want you to get in trouble. So we look for really what problem you're trying to solve and how it would fit into the solutions in place. We think a lot about not only the technology, but also the people and processes that it would require. I think, and I'm sure we'll probably get to this, but when you think about something like telemedicine and a digital app, that the technology is not the barrier. So we really try to focus on things that we evaluate things so that we can not only tell what the technology and the solution is, but also the impact it'll have on the ecosystem that we operating in.
I mean, I think the question of feasibility relates closely to our various users going to be motivated to use this innovation in practice. And this is something we talked about when we gathered before the panel, but I think a lot of that question comes down to sort of a cost-benefit calculation on the part of each step in the user chain. For patients, that may be an implicit cost-benefit sort of calculation. Does the benefit I derive from the time and effort I spend using this application or entering data or whatever, does that justify use? From a system perspective, that may be an explicit cost-benefit calculation. But I think understanding the sort of cost-benefit implications along each step of that chain is really important in determining ultimate feasibility.
I would absolutely agree with that. And again, in the settings in which I work, it may be somewhat different from a lot of the visions for the digital applications that many of you entrepreneurs in this room have, because we have to balance between everything that Matthew just said in terms of the cost effectiveness and sort of that, what's the value add as you move up in the chain. But particularly, we often are serving a given population, which is low income, bottom of the pyramid, as we call it in our space. And so there's a tension between, is it feasible? Will this user enjoy it, whether it's the end client or whether it's a provider? But we also have to think about what the ultimate financial sustainability is going to be. And so sometimes we are required to continue to inject this donor funding, which from a lot of people's perspective would mean that it's not truly feasible or it's not truly scalable. But there are certain contexts in which that remains appropriate because there is no other business model that's going to be effective. And yet, as we're seeing, and through a lot of work from people like you, we can bring a lot of the business and entrepreneurship models to our settings and identify certain segments of that population, whether again it's the end client or in some instances governments who have funds that will be able to put those resources toward it. And so actually true business models can come in. And so we're in a space and sort of a transition period right now in the global digital health community where we are somewhat grappling over this issue between what's the affordability and what's the ultimate financial sustainability. So that also factors for us in particular into our equations around feasibility.
I just was going to tag onto that and mention that we can't forget about the 20% of people on that slide who don't have smartphones. I feel like there's a pretty good proportion of my patients who either don't have smartphones or can't pay for them every month. And I loved what you sent out with the 9 principles because the first one is design with the user. And the user can tell you exactly what their technological capabilities are. And that's really important.
Yeah, no, and we did a project as well. There's a lot of emphasis on, iOS apps, and we tried to enroll 30 patients into this study for CHF and COPD and could only enroll 2. And the reason was because 90% of the patients that came into the clinic with these chronic comorbid conditions were coming in with Android devices, not iOS. So I think it goes into kind of what you're saying, which is almost know your community, right? Know the people that you're really targeting this with. I'd love to take advice for that, but actually Harriet said that at our pre-meeting, so I should just be honest that I didn't come up with that. But yeah, know your community. I mean, know if you're trying to design a digital health solution, who are you designing it for, and will they actually be able to adopt it? But with all of you, I mean, are there examples of solutions that you have seen implemented that were actually highly feasible, that did show a lot of success and in that integration into the care setting? And what were kind of some of the hallmarks of that? Like why were some of the ones that are kind of coming up in your mind highly feasible, and how do they separate from others? I'll start with anyone on that one.
So at FHI 360, we were involved with developing a very simple SMS-based information service, so direct to clients to provide information about contraceptive methods. And this has proved, in my opinion, to be, I'm biased, but my opinion to be very successful and feasible. But I'm going to actually talk about it in 2 different ways. So where it was feasible and then where we still have challenges. But to the feasible point, and the reason that I think we've reached a national scale in Tanzania and we've now introduced in multiple other countries, and we take a very thoughtful and rigorous process and long process in some instances to actually identifying the best content to deliver for the users and the best platform to do that. It was originally SMS based. We've now been working with other partners to provide it in IVR form so people can just call in to make that available on also very kind of low bandwidth websites. But we, through multiple iterations, we're able to sort of identify the key steps in a process, which we've recently published on, that shows how you must be thoughtful and rigorous in conducting not only kind of key informant interviews with decision makers who can easily say no to whatever content it is that you want to provide to people in a lot of the contexts in which we work, but also to providers to make sure that they're comfortable with that, but then certainly with the end users. So we do a very kind of iterative process of developing that content and testing it. Again, nothing new here, but it can take some time, and I think that that's something that sometimes people are unwilling to do. So for me, the fact that we were very thoughtful in targeting our end users, but also those people who would support and facilitate the scaling process for this particular intervention in the context in which we were working, led us to achieve these very high numbers, and now it's been operating for 6 years in Tanzania in particular. So.
Anyone else on examples of?
Yeah, I think what comes to mind for me in response to this question, Will, is that we, as I mentioned, I am an endocrinologist, take care of a lot of diabetes patients, and do research through VA, as well as other funders. When I was an endocrinology fellow, I kind of had the observation, as I alluded to earlier, that I was really struggling with some patients in the clinic setting. No matter what I did, it didn't seem to make a difference as far as diabetes outcomes. So got to thinking about this and said, well, this maybe is a real area for clinical need. Looked at research that had been done, did some observational research to look more specifically at this group of patients that maintains an elevated hemoglobin A1C despite engagement with clinic-based care. And we developed a solution, comprehensive telemedicine intervention that combines telemonitoring, self-management support, and medication management that we sort of specifically developed with this group in mind. I got some pilot funding through the VA to test that intervention, and it was effective, lowered A1C for these folks. Down the road, as a result of getting the word out about this project, we were able to engage with the VA Office of Rural Health, who is now funding us to implement this intervention in Asheville, North Carolina, at that VA center, with plans to spread that to some other centers coming up. So, in a way, working within VA, you really benefit from the fact that it's a top-down system and there's a lot of homogeneity in terms of available technology and staffing. But I think that some of the reasons this was a successful project were that, A, we started with a clear clinical need. These are patients who are struggling. Everybody struggles with them. And they're struggling themselves to try to improve their health. We developed this intervention approach with our systems, staffing, infrastructure, technology in mind. And we were able to engage with some key stakeholders, in this case, our operations partners in the Office of Rural Health.
I might, unless you have something you definitely want to, I was thinking about, I want to leave time for all of you to ask questions, but the opposite of that, what about people that have come up to you with ideas that just were not going to be feasible? Like, what are the things that you personally see whenever someone comes up to you, approaches you with an idea or with a technology that this just isn't going to go anywhere? And why is that? What do you evaluate? Yeah.
I can speak from our perspective. There are a lot of one-off ideas that are what we call point solutions, but they are actually just one step in a very long chain, and folks don't necessarily understand how that point solution will impact the rest of the ecosystem. So, for example, folks love, recently I've talked with a bunch of folks who have text-based technology, which is fantastic, right? Really great use. But that just sticking text into something, you really need to understand, well, why would somebody be texting? And what would they be using it for? Who would support that? What's the expectations as far as when somebody would get back to you if you text? I mean, that's a very immediate thing. So a lot of great, cool AI chatbot stuff out there that is making chat experiences better. But that's just one area where if you're just trying to solve one little problem and not understanding how it fits into the bigger value creation and calculation for your target audience, I think you're just not going to go anywhere.
I will talk about just another example of knowing your community, and I think that's knowing the people that you're trying to sell your product to. And so the example I would use is we get a lot of vendors coming to us with potential solutions, and I think they approach it like they would with any other practice, which is you're a business, we're a business, let's talk business. And they don't really understand that we really operate from a mission-based perspective. And so just knowing your audience and knowing your community in all the senses is really important. And I do want to just speak about one example that was feasible, and actually is part of the reason I'm here is because it was feasible and it's successful, is some of the efforts of Dr. Gary Bennett and the studies that they've done out of with our patient population. And so these are weight loss or weight maintenance programs that have been implemented in communities of medically vulnerable patients. And I was just thinking of another example of sort of how they got past this, the knowing your community and being open to designing with the user, which is their most recent project, which is Project Balance, is starting out of our Carborough clinic. And I got to go to the meeting where they talked to the providers at the Carborough clinic, and I forgot to warn them that these are some of our most challenging providers. They've been there the longest, and they know what they're doing, and they really know their patients. And so that can lead to being a little bit resistant to certain ideas, especially if there's any sense that the people coming in don't know the community. Fortunately, we know these investigators, and we've had great experiences, and so that wasn't the issue, but there's still always some resistance to change. And I just really appreciated that when they did come in and talk to our providers, there was no getting defensive about the ideas that they were bringing up. They listened and actually made changes and changes in design, and that was, I mean, they just hit a home run by doing that. So just being open is the other thing.
I guess just to add on to what you're saying, I think a big point about when I talk to very enthusiastic technologists is to appreciate the change management that is required for whatever you're doing. And I would always say, and it was exciting to hear about telemedicine and remote monitoring really working. I think diabetes has been a huge success area for telemedicine, how it's been linking people together for better care. But really primary care visits for telemedicine really have not gone off, even though all of us would say, wouldn't it be great to just see my doctor whenever I want? And there's so many different things related to that that really make it not viable, and it has a lot to do with having a change management mentality on the part of the payer and the provider. So,
Yeah.
One thing I would just mention quickly is that I see a lot of apps that are targeted towards data collection for diabetes, and one of the things that can be challenging with that is sometimes these solutions will create sort of a parallel system of data collection apart from the existing electronic health record. As a provider, that is a real challenge to have X number of things you need to accomplish during an appointment in the first place, and then have to figure out how to access this other data repository, understand how to use it, and then make decisions based on that. Easier said than done. I know people are certainly aware of the benefits, potential benefits of integrating with existing EHRs, but the more that can be done on that front, I think the greater the chances for feasibility.
Well, now I'll open it up for questions, but before I do, I'll just kind of summarize here what I heard. And the first was, if you're going to design a digital health technology, know your community. If you're designing it for someone in particular, get to know who they are. What are their lives like? What are the challenges that they would see with this type of intervention, so that you can try to mitigate those on the ideation phase instead of after you've tried to pilot something and it's gone incredibly unsuccessful. And the other thing is, what is the cost-benefit analysis? I thought that was really insightful, right? For everyone within the value chain. So for the patient, if you're coming up with a new glucometer, right? I mean, like, how are you delivering these things without giving patients a chore to do, right? Oh, well, we want to be able to get more information on you to see, what are the fluctuations in your daily glucose, but to do that, I need you to do a daily chore. How can you make things a lot less costly, not financially costly, well, that is important, but costly in terms of kind of an interference in your daily workflow. From a provider, Jane, you mentioned, how does this fit into the current workflow, right? And I think that's something that Drew mentioned as well. It's really fun to talk about disruptive innovations, but disruptive innovations is really difficult in healthcare, right? Because if something's too disruptive and it doesn't really fit into the current clinical workflow, the chances of you getting through a pilot is very slim. And then in terms of a system, we haven't really talked about this, but how are the providers getting paid? And is your solution actually going to help that or not? Because that would be a way by which you get a pilot going, and also something I'm sure a VC will likely ask as well. And you'll hear more about that at 2:45. But anyway, are there any questions for this panel?
So how do you identify the need of future customers and the innovation process that you use to stay ahead of the next opportunity?
To be honest, I actually didn't even hear the question. Can you repeat it?
I sure can. So how do you identify like the next customer and kind of the opportunities that solving for those problems might bring, which kind of is the second part of the question, which is how do you manage innovation? Are you having a yearly kind of innovation summit? How do you interact with people to get new ideas to solve for those problems?
I can just speak for kind of the global digital health space in low and middle income countries. I think there's an interesting thing that is happening whereby we're talking about leapfrogging. So in some instances, we went from very resource poor settings and people only using, basic phones and SMS to sort of jumping straight to smartphones in certain countries like Myanmar, which maybe is not truly an LMIC, but depends on where you look. So we have to be mindful, again, using as much data as we have, so pulling from what available data there is. For example, we're constantly looking at GSMA data and others to sort of see what are the technologies that people have access to help us better understand. That's one point. But being parts of communities of practice and just global networks. And so those exist at country levels. And so we are very much a part of country level digital health communities of practice, which is where you can hear some of these things and what sort of trends are coming up. But there also are similar global communities of practice. And that's to kind of the second part of your question. You start to hear great ideas and in a fairly kind of open, free exchange space. It's slightly different for us since we're both kind of competitors and collaborators in the donor community. It's maybe a little bit more open for exchange than it might be in the true kind of entrepreneurship space. But those are just the ways that we kind of anticipate what those needs are.
I think it's something really important as far as the first part of your question, identifying needs, is to maintain a close dialogue with your patient and provider stakeholders. I mean, I don't think it's a mystery to most people who are providing diabetes care, for example, that this is diabetes is a growth industry. Prevalence is increasing. Complications are, maybe in some cases improving a bit, but as the population ages and obesity becomes more and more of a problem and diabetes is more prevalent, these problems are not going away. As far as identifying the next thing down the road, I think providers in the domain you're interested in and patients as well will have a great perspective on that.
Any other? We have, I can just tell you quickly about DHI. The way that we currently do it is we work with senior leaders from across Duke Health to identify what are the strategic and thematic areas that they personally see opportunities to develop new models of care or take technologies and integrate those into the care setting outside of just like standard process improvement. Like where could true innovation be housed within the health system? We get it, we put out an RFA, we get back roughly each year it's 60 applications. Then we spread those out to about 40 evaluators from across the health system to evaluate on different metrics, but really one of the main questions we ask is, would you personally invest in this? And then we get down to about 20. Those present to those leaders of Duke Health, who then end up funding those. So it's those people that kind of have a strategic eye of where the institution is going, understanding not only the patient but also maybe some of the maybe evolving payer contracts that could help us maybe think differently. So that's how we personally do it. That's a good question.
Can I make a comment? Actually, in building on something that Harriet said earlier, that I think is profoundly important, and that's this idea of the mission being your motivator versus entrepreneurial concerns. I think from the perspective of most providers, if not all, it's really the mission that drives what we do. And how does an innovation or a solution integrate with my mission, for example, which is trying to help diabetes patients who are struggling in the clinic-based setting, is something that would be of great interest to me in discussing, solutions with different folks. Part of the problem here is that poor diabetes control, for example, and poor control of many chronic diseases tends to align with various social challenges and other factors that perpetuate poor control. So, if, for example, I have a depressed diabetes patient who is non-adherent and uses a flip phone because they don't have much money, how can digital solutions potentially benefit that patient where there's a great potential for absolute benefit? I think that's a challenge for everyone in the room to think about, how not to forget about some of these folks who could really benefit from digital health solutions.
And I would say there's also, you said innovation, but we need to think about innovation not only for consumer and facing solutions, but also for business innovation, and really looking at how digital solutions can help the process work better. I think about Validic, right? It's trying to tie together business partners in a new way, and I think thinking about how you're helping the business partners deliver their solution is really ripe for opportunity and innovation.
Ed.
Hey, well, great panel discussion. I wanted to ask a follow-up on the EHR integration conversation. So my name is Ed Holsworth. I'm president of Little Green Software and co-founder of Pattern Health Technologies. And at Pattern Health, we were one of the first companies that integrated with Epic's EHR back in 2015, and it's and we have.
Congratulations.
Well, just wait. We've at Little Green, we've probably done half a dozen EHR integrations now with the new Smart on Fire technology. So it's a really exciting opportunity, and it's one of the first things that a provider will say is, are you integrated with the EHR? But lately I've been finding that I have to tell the providers, well, yes, we have that capability, but there are all these hoops that have to actually happen to actually roll out a solution that's integrated with the EHR. And even many of the Smart on Fire technologies that are these integrations aren't going to be available in Epic until 2018. And then will that version be available at your healthcare institution? So my question is, what's your advice to those enthusiastic technologists and who would like to create those solutions, but are working in this sort of real world of where the EHR integrations are still a little bit behind what everybody would like to see?
Go ahead. I mean, I'm willing to take a stab, but you go ahead.
I don't have a true answer, but I think from my perspective, we are not on Epic, believe it or not. We are on GE Centricity and quite happy. I think sometimes low tech is okay. So I'll just put that out there. And if low tech makes it easier to integrate with different versions and different systems, that might be okay.
I think you highlight a really great strategic choice for any health developer, digital developer, is pick which market to pick. I mean, to say that I'm going to get out of the gate and offer enterprise-wide solution for an academic medical center may just not be the right target audience for what you're trying to do if you don't come with the requisite connections to be able to absorb and develop an EMR integration. You can have Athena, GE, Centricity, who really try to have a more open environment and in the ambulatory space and in the clinic space. So that is probably one of the key decisions you want to make as to who you're actually trying to design for.
Yeah, I mean, Ed, yeah, I would say that's a brilliant answer, right? Who are you trying to design for, right? I mean, I think that, whenever you talk about like true proper integration, like you're going to have to go through all the necessary steps, right? At Duke, we have our processes, UNC, they have theirs. Anywhere is going to have their own processes. And it does include working with wonderful colleagues in the Information Security Office to make sure that everything's aligned properly. It goes to the CTO's office to make sure that this is kind of in their roadmap of the things that they want to implement. But the thing that I would also say is, as important as integration is, and this is just from my perspective, integration should be the second thing you think about. The first thing you should think about, again, this is personal opinion here, should be finding someone in the clinical setting that's willing to champion your idea and is willing to implement it outside of putting everything in production into Epic, right? And being able to prove, because think about it, there are millions of digital health apps out there. It's really impossible for any of us to know which ones work and which ones don't because there haven't been proper validation on all of these. So doing what you can to prove the validity of your product, the clinical utility and the economic utility, then once you prove those, that becomes a lot stronger of an argument to be able to ask for integration once you get there. But if you start there, you're almost just fighting an uphill battle because in my mind, if I was at that stage, I would say, why should I spend all these resources working to integrate your solution? I just heard from 10 other vendors, right? So just working with a clinical champion that you can do kind of an early stage validation. Thanks. So we've ran over time, but I thank you to the panelists. This has been a wonderful panel, and y'all are all amazing. So thanks.